Let's see, I gathered myself here in 5 minutes. Approval of the agenda. Would somebody like to approve? Move to approve this?
I move to approve the agenda.
There's no objection, then we'll consider the agenda approved. Is there anybody from the public who'd like to speak to this board? I don't hear anyone. Okay, we'll move on from there. Did anyone else have a look at the minutes?
I did. Move to approve the minutes. Small packet.
Second. Okay, if there's no objection, we'll consider the minutes approved. And we'll move on to new business. And then Gail. First.
All right.
I'll let you introduce.
I am here with Jeanette Lacey. If any of you have not met her yet, she's our Director of Case Management. And we chose this topic to bring to the board. This kind of came out of our risk assessment when we're looking at our limited English patients. And that came out of section 1557. And so we thought we would bring this education through to the compliance committee and why it's important. And so I'm gonna start doing the presentation and Jeanette's gonna jump in because this is really a key area for case management. And they oversee a lot of the programs that we do to keep us compliant with this regulation. So that's our education for this month. Does anyone, are you aware of the section 1557 before we get started? Okay, I see someone very.
I will only for reviewing material.
Okay. All right. So the way we're starting out of it as the overview of it, and you can go through. So the goals that we want to do is we just want to give you an overview of why 1557 is in place, and then what 1557 covers, and then what we have at Bartlett that is showing that we are compliant for it and giving you a chance to ask questions on what the program is at Bartlett and if you have any concerns and how we can do better. So if you want to go down to the disparities and access to care slide, Nathan. So you can go to the next one. So as a general overview of access to care within the US, pulling these numbers out there. So you can see that access to care for American Indian, Alaska Native individuals under 65, they generally have an uninsured rate of 28%. So it's actually a pretty high rate of uninsured. That has changed a little bit because Alaska does participate in the Medicare expansion. So Medicaid, thank you. Medicaid expansion. So that's one thing that Jeanette's team and PAS identifies people coming in. So we try hard to get people to be enrolled and come in.
Yeah, excuse me, would you like a question as you go, or would you like to also it to the end?
You can ask them when you go.
Yeah, that's probably easier as you go.
When I first came across this really puzzled me because there's the Indian Health Service. You're here in Juneau, beneficiaries of search. And so it's different than other ethnic groups who are uninsured. How does that all relate?
Well, first of all, like Gail said, we have Medicaid expansion. So the hospital participates in a program called Hospital Presumptive Eligibility. So when somebody comes, or HPE, so when somebody comes in and they're uninsured, we do first try to screen everybody to see if they would be eligible. We have a screening process that we can do in the hospital, and if they screen in, then Medicaid will cover at least this stay, and then they have a little bit more time to get enrolled fully into Medicaid. And insofar as our IHS or Indian Health Services, so if our Alaska Native population is enrolled in tribal health, then as a last resort, CERT will pay for healthcare. However, CERT that does not cover behavioral health, so no mental health admissions and not substance use treatment. So that's a big barrier. Exactly.
No sense when they are overrepresented.
Right, so that's that could be a challenge, but most of the time, we see very few patients that we're not able to get on some level of coverage anymore. But they still occur, like if they're, you'll see people who maybe are fishing in the summer, or if they make too much money overall, then we can't get them into Medicaid. So there are still people, but nowadays, most people that are uninsured, we can.
People who are part of a recognized tribe or an Alaska Native group, they don't have insurance. How does that, they may not have insurance, but what is Indian Health Service? Isn't that the insurance equivalent?
Well,
Whether we're
Search
talking about-
always, they're not an insurance, but Search IHS will pay for healthcare costs. But again, like I said, like if they come into the hospital and they can't for whatever reason become eligible for Medicaid, but they're a Search beneficiary, Search will cover their hospital costs, excluding mental health and substance use treatment.
And then I think I did have a comment. I think that the 28% is what shocked you that it's that high. I assume that's a national
That's
statistic.
a national
Correct.
statistic.
And so in the state of Alaska, the rate of lack of coverage for natives is extremely small because of IHS. But your natives down south, for instance, in states of South Dakota don't participate in the Medicaid expansion. So that's where it comes from.
Okay, thank you.
I assume.
Yes. The second bullet point on it, and this is just, again, is a national average, but it also is our highest use of our language line is Hispanic Latino group. So Spanish is the number one use of our language line right now. So that is 29% of uninsured. So that is a national average. I didn't have data for just Juneau itself, but I thought that was an interesting correlation there. So you can head on to the next slide. When you look at quality of care, when you look at disparities, this is just some interesting national data that came out of the 2021, so it's pretty relevant, the National Healthcare Quality and Disparities Report. And this looked at comparing different ethnic groups to people who identified as white compared to other ethnic groups. And it was looking at measures of care in patient safety, person-centered care, care coordination, effectiveness of care, healthy living, and affordable care. And it had 195 different quality measures, and it just rated it out in different areas. So this is how each of the different ethnic groups compared to someone who rated them identified as white compared to different ethnic groups. So it does, looking at it as a national level, that there are social determinants of health that are affecting it. And when you also look at it, that there's probably some limited language and other social determinants of health that are probably affecting the quality of care.
Mr. Chair.
Oh, yes.
My question is, it looks here like not all ethnic groups were rated by the same quality measures. Why would that be?
What this is.
Based on the number that's reported.
What this is these are only the quality measures that they rated lower in. So they all rated as 195, but then these are the ones that they showed worse than white. Some of them that they were equal or higher. These are only the percentage of the measures that they came in either less than someone who was considered white. Okay. So that's why there's different numbers in it.
Thank you.
So like some nationality or ethnic groups actually didn't look as bad as others. Next slide. Maternal health, this is also looking at if you're non-white, you have higher risk of mortality and other complications of birth. Again, another statistics out there that are pretty well studied. And then health equity in when you look at discrimination related to sex, age, and disability. Next slide, Nathan.
Could I
Sorry.
ask you a question about that last?
Yes.
Could we see the last one again? It's the very last sentence ends with suggesting the elimination of racial ethnic disparities in provider. As I read that, it doesn't suggest that those disparities are eliminated to me. I'm not sure. Could you explain the point you're trying to make with that second bullet?
So this was a quote from this that landing costs.
Couldn't it, I mean, as I look at this as a nurse, you know, Alaska Native women have more mortality from hemorrhaging and so forth. That may have to do with their lifestyle and their genetics and so on. I mean, it seems to me like there's a lot of reasons why this happens.
Right. Yeah, I mean, there's more study that could be found, and that's exactly it, is, you know, is there other causes for it? So.
Okay, thank you.
And that's why I did make sure I put all my references on.
Good, thank you.
And then the other factors within that you'll see in 1557, it does address the LGBTQ communities within it. And there, if you go to healthypeople.org or other things, they are realizing that they are studies now that are showing that they have a higher risk of poor mental health, other physical health, including depression, anxiety, post-traumatic stress disorder, substance use, and there are studies that are actually showing that cardiovascular disease is increased in LGBTQ communities now. So that's significant to find. Ageism is a thing, and this study from Regis College was actually quite interesting to me about that. It found that the older adults were reporting that their pain was ignored for longer periods of time. So that was actually a really, if you go to it, looking at the studies of Regis College, because our population in Juneau is aging out. So that is something that we need to be aware of as a hospital system, is meeting the needs of our aging population. And then the health affairs study on disabilities. That was another quite a shocking one to look at, is care of people with disabilities, making their preferences. So this is the background of why section 1557 is in the code and why it's important. And what is it? So 1557 is the non-discrimination law, part of the Affordable Care Act. It has added when the Affordable Care Act came in 2016 and they made some expansions on it. The goal is to expand access and eliminate barriers and reducing health disparities. It wants, like we've always had, prohibits discrimination on race, color, national origin, sex, age, and disability. It covers a lot of different organizations. It specifically covers us as a hospital. It also provided some new civil rights protections, specifically related to LGBT. And I'm gonna just shorten it because I have a tongue twister there. Some of those are being contested within court, but we need to be aware of what we're doing for our community on it. Next slide. On it.
Excuse me, there's a
Yes,
question.
I have a comment.
About the contest, the court actions that are happening. What a lot of people don't understand is just because the federal government has set these protected classes does not mean that we have to be limited to those protected classes.
Yes.
We as an organization, whether or not any of those classes are excluded through court action, we can continue to include them in our policy.
Absolutely,
Yes.
and we will.
Yes.
Yes.
I assumed we
Yes,
did, but a lot of people just don't understand it, that
Right.
they feel that they're gonna be excluded. If the court action takes place, they're gonna be excluded. That doesn't necessarily mean that.
Yeah. And the court actions are very limited to, are you a religious organization, the type of procedures that they're requesting and the type of procedures we are offering. What is happening is really a lot of outside of the scope of services that we provide as an organization.
Through the chair, to your point, that the CVJ code actually includes many of those already. So as a city, we're bound by those.
So one thing that we're working on right now is just eliminating the gender, sex at birth, male, female off of our armbands. Because there's really nothing that we use it for identifying whether you're giving a medication or anything. It's really an archaic thing to have it listed on your armband. So, and there's 90% of the hospitals throughout the state don't even have it on their armbands. So that's something that's left over from years ago. So that's one thing we're doing now because it's a triggering for people. So we're really looking at our policies and our procedures very.
Yeah, lots of education, working with staff throughout the organization, ongoing education with everyone.
So, okay. Limited English proficiency. This is one big area that we looked at when we did our risk assessment, our annual risk assessment. And do you want to talk? I don't really want to read the slide. This is kind of your area of expertise. Do you want to kind of?
Yeah, sure. So, when this came out in 2016, we did a big overhaul on it's in, our policy tech is our communication plan. So it is related to different languages, including ASL, American Sign Language. It's also includes limited hearing. So, there is a deaf community and there's also people who are hard of hearing. And so how are we communicating with everybody who is not, able to speak and hear English? So we put into place lots of modalities to provide access. So our primary tool that we use is called Language Line, and we have it now through an app on an iPad to try to make it really easy. In the old days, we used to have a call-in number and get it on and give them the phone and back and forth, and it was, so it's really nice now they have it through an app, and we have the iPads on like rolling stands that we can roll into the rooms, and you just pull up whatever language it is, and that really works well. We also have ASL on there, so we have voice. We usually just use voice. There's a pretty big cost difference between voice and video of like the interpreter, but obviously you need to use video when you have ASL, so you have sign language. We did get a lot of comments back from the deaf community that they would like to have the option of an in-person interpreter if available. So we do have one. And so staff can try to, obviously she's not going to always be available, and it could be an emergency situation, but particularly for things like a pre-op appointment or somebody who's going to be here for a while, if it's more comfortable for them, we would like to coordinate an appointment with that person to come in and be available for that. And then we make sure that we have amplifiers, headphone amplifiers for patients too. So if somebody is hard of hearing, that those are available on every unit, so that we can try to communicate better with our patients who need that. So really, it's a pretty big policy that explains all of why we do it. We have steps in there about how to assess for limited English proficiency. So it's really just based on how the census workers were assessing that, and it's do you speak English at home? Do you have any difficulty? And basically it's a really low threshold to offer the services. We're mandated and obviously ethically should be offering this to anybody with limited English proficiency. We must also inform them that it is free. We want to make sure that they know that it's not something they're going to be charged for. If they prefer to have a family member translate, which a lot of people do, it's fine, but staff also need to be aware that if they have the sense that, number one, either the family member doesn't really understand, they're not quite getting it, if they seem, or it's really complicated, or if there's any concern of maybe they're not translating everything that we're trying to say, then we do sometimes say, let's just get that interpreter in here and make sure everyone's clear. And then kids are not to be the interpreters unless children, minors should not be the interpreters unless it's an emergency situation. That's pretty much the main piece of it.
So do you go to the next slide? So on the bottom, and you guys probably read it in your packet, so it was interesting reading about the medical malpractice claims that they came out and so when healthcare providers talked about that if there was patients identified that they had limited English skills and it was not documented that they used or offered a interpreter. So documentation, and my slide got cut off somewhere in the process of uploading it. But that is something that is important. So if we are not using interpreters when we need to, especially when you are consenting, providing discharge instructions, those critical areas of patient care, that it can be considered medical malpractice. So
so that goes back to like making, staff feeling comfortable if they feel uncomfortable that it's not getting through, to just say, let's just try this, let's pull this in. And I don't know what's on your next.
Just enforcement. It's the Office of Civil Rights. You know, I put the last slide is the slide that you never want to see who comes in.
Oh. Well, I'll
Yes.
just add before this then, I guess. So we do have Patient Safety Week in March.
Yes.
So one of the things that we're gonna be doing, we put up a poster board last year just with all of the information, but this year I'm also gonna be taking the iPad around to the different units and you can use the app, and just when the interpreter answers, you can just say, oh, this is a test call. So like just bringing it around, letting staff play with it, letting them feel comfortable, just so that there's no hesitation. That's the thing, is I think the biggest thing is people don't really, if they don't feel comfortable to use it, they'll try to make do. And so we don't want people to make do. So just trying to really get as many staff as possible used to seeing it. You know, we always have new staff used to seeing it. We talk about it in new employee orientation, but we don't actually bring it, have it in there. So hands-on practice for staff that week. So.
And then
Anytime they could come and ask me, I'll show them how to do it. So.
And then the other thing we've identified with this process of doing this assessment is looking at our documents of which documents we have in our top languages.
Oh, that's, something I was
Yes.
gonna tell you. They're gonna give me a report for all of the documents that we've requested translated for the last 10 years. So I'm getting that over, because we've had various things over the years translated, so.
We just don't have a place, that's one of our improvement projects we don't have a place of where staff can readily access any of our translated documents.
All the shared documents, so
Yes.
like maybe somebody in PFS had some things translated and they have it.
For consent.
Or for whatever billing, or if, admissions got something, well, they have it, but.
Yeah.
Not, so we need to have a shared area where anything that gets translated can be.
Readily
Stored.
accessible and stored. And then the other thing we've been working on the last 2 years with Harvard Medical School is each year they do a class in their graduate class on limited English, and we send documents to them to translate and evaluate for us for limited English, and they'll put it to a 5th grade reading level. Health literacy. So that's a project we've done for the last 2 years for their graduate medical education with Harvard, which is part of this also because some of our documents that we've sent over to them, they've evaluated and they've been written at a 10th grade reading level. So,
Trying to prove that.
which the average American reads at about a 6th grade reading level, so.
I have a question.
Cheers.
And if I missed it, I apologize. About how many languages do we generally translate into? I mean, there's the usual suspects, but
You know what I was, do you know what I was surprised about? That our fourth most common call was Czech.
Wow.
Spanish, Korean, Vietnamese, Czech, Cantonese, those are our top 5.
Wow.
Summertime, we have a lot of tourists.
Oh, the guys working out at the cannery. fish cannery.
Oh.
We had on the list, there was about 25 different languages that were utilized last year.
Yeah, top audio languages. 1, 2, 3, 4, 5, 6, 7, 8, 9. Well, they broke it down to like 9,
Yeah, and we have more.
and then it has other, which is Russian, Czech, Vietnamese, Korean, Spanish, French, Indonesian, Tagalog, Mandarin, Cantonese.
The reason I asked is when my kids graduated from high school in Anchorage, their school was the most diverse in the United States at the time. And 42 languages were spoken in that school.
Where was that?
East Time in Anchorage. 42 different languages were spoken when one of my daughters were. So we had a lot of interpreters and both ASL and other languages that the school district had to provide for. So I just wondered how pervasive. Alaska is a very diverse state, as we all know, but
when this first came in, they did our top 15 languages. And it was actually interesting because it was now our top 15 languages that they did when this first came into law. They're not the same. So that's one thing we're looking at, because we never did a full assessment and made sure we fully integrated it into all of our forms since all the work was done, and our language list of usage has definitely changed.
And then, oh, sorry,
Oh, no, go ahead.
sorry, I don't,
Complete that thought.
I'd like to add that we aren't able to access any of our Alaska Native languages through this app because it's there's just too rare, like they're not gonna
It's a
have.
national program.
Yeah, so we have, and so we do sometimes, it's pretty rare that we'll get somebody down here that only speaks an Alaska Native language. But we have had it, especially we do have our mental health unit that has patients in from all over the state. And so if you did have somebody, we are able to work with some of the remote clinics. We'll call them, and so we just get creative in those types of situations to find out who can help us. So I haven't had that happen for a while, but it has happened, so.
When I used to work out in Western Alaska, there were a lot of people who only spoke Yupik or something. But that time's marched on. Those people have been replaced
Well,
by people who were young then.
there's still some people that they don't speak English, or it's very limited.
Nathan, did you have something you said?
I was just gonna respond to Deb's question there, that in regulation, most of the federal regs that do require you to translate, it is that 15 number. 15 languages are required. And to Gail's point, I think the assessment is usually a demographic based off of the city itself. But as we find out that if we don't have a big Czech population that actually lives here, then that might get missed when it comes to the amount of Czech languages that we're requesting for translation services. So there's lots to look at there.
So are we done with that topic? Anything more?
If you have any other questions?
Well, I have a question. Do you have a list of people like in Juneau that can be interpreters?
We don't anymore. Long ago, we did that. Yeah, long ago, we used to do that, but I think I wasn't part of the change of that, but I think the issue was that it was really hard to keep up certifications. It was a big process of keeping everybody certified. And the other thing too, now, I mean, a nurse can, or a doctor, whoever, can just go click a button on an app and they have immediate access to a translator versus trying to find somebody on the list, call them, see when they can get here. It's a long delay. So
CMS.
So is this, the app, is it a real person there?
Yes,
Oh, it's
yes.
not a computer thing.
Oh, no,
Oh,
it's, no, the program is called Language Line and Language Line Solutions. And when you click on the app and you click on the language, it could take a minute or something. And then you're not on the phone, you're talking through the app and you let them know what language you want, and then they help find an interpreter, and that person comes on the phone and, through the app, through the iPad, and it's just available right there.
So is that somebody at home cooking dinner for the kids and all of a sudden the red phone rings?
Well, I guess I don't know that side of it, but perhaps it could be, I don't know. Yeah.
Well, how does patient confidentiality come into that? You've got somebody who doesn't, know this person.
Well, it's all,
Going through.
Yeah, I mean, we have all the agreements with them for confidentiality, and they're a certified agency that we have like a
Corporate.
BAA, yeah, we,
So yes, business associate agreement with them so that they know that they're supposed to follow the HIPAA rules. But to your point, Hal, I mean, even if it is someone that's cooking dinner and they get the bat phone call, they do have to be certified in medical translation.
right.
There is a standard for that.
Yeah.
And that's why working with this agency is a lot more streamlined for us, because anybody that's working for them has to meet that certification.
We used to, before we had the language line, when I was in education, I'd have to, if we had someone local or an employee, we would have to have them certified, and it was a process where we would have to have them test to become certified, and it would be a national certification. And it was challenging to keep it up, and we only had a few employees who would be certified in different languages.
Sounds like a great tool.
Yep, and it's good timing to start getting everybody, more, just refreshed or whatnot, because the boats are coming. So,
For the emergency room, it's the best way, it's almost instantly.
Should we move on to Nathan's risk assessment?
Thank you.
So is it the right or the left blue button that I need to?
Hit a net,
This one?
yes.
Okay. The long-awaited risk assessment. So just a recap, refresher for the group. Every year, it's advised that we put together a risk assessment. And this risk assessment is a reflection, the one that you have in front of you is a reflection of our internal risk. So the way that we go about this is through either observation or through interview or also through questionnaire, talking to the different groups within the organization and then their feedback, and then follow-up feedback when there's questions. And then all of this gets distilled down into a list of different areas that would be evaluated for whether or not it needs attention. The way that I have this set up as we scroll down here is the left-hand column is a running numerical value. So for every area, you're gonna have a number. You scroll down to the bottom and you can see we've got 34 unique items. But then under each standard, the numeric value restarts. So you know that we've got 2 underneath this particular topic. The other thing is we've used this slider kind of quick and easy, hopefully quick and easy way to look at red, yellow, green, kind of a stoplight methodology for where we feel that each of these different areas ranks out in a priority. And happy to answer any questions as you have them. One other item is that this color also is reflected of the slider. So as you scroll through it, you might see some oranges here because the area is orange, and then you might see something a little lighter, then so forth. And the greens, we did not add that as recommendations because they're in the green area. One thing of note, I'll just point it out, our highest is under strategic planning and new service lines. And this is a result of our new service lines that we brought on. Interestingly enough, and Jim, you haven't been on the board through the last year, but some of the things that we've had to do as a board in a hospital is to make sure that the board understands that some of these new service lines actually require, by regulation, a board. So it's not like it's a new service line that you're rolling up underneath the hospital. It's a whole nother licensed entity. And as a result, this last year, we've added 5 new licensed entities. So we've got home health, we've got hospice, we've got Wildflower Court, and crisis observation and crisis residential. So 5 different licensed entities.
And they each have a board, huh?
They're all required to have a board, yes. So so what we have done is change the board bylaws to include various licensed entities so that as a board, you guys could vote and agree that you will take on the responsibilities of those particular licensed entities. And as per direction by the state, they have allowed us to have one board meeting, but they have also clarified that they want to make sure that we have distinct spots within the meeting to where the transition is clear as you're moving from one licensed entity to the next, that you're talking about that business area. So you don't have to close a meeting and then restart it under Wildflower Court, for instance. And then stop that one and then start another one, right? They'll allow you to move that business through, but it's got to be clear. And this is an important piece of how we track the minutes also, so that that can be demonstrated in the minutes.
Does that mean that there'll be a committee of the board for each one of these entities?
So that's a possibility, but at this point, I don't believe that that has been brought up as a thing. I know that different licensed entities do have different requirements for types of meetings, and maybe Gail could speak a little bit to the quality piece of Wildflower Court. They're supposed to have their own designated, what do they call that meeting? There's a special meeting that is a quality meeting, right?
Yeah, and Lisa, actually, that's one thing that's on her governance committee, is looking at the bylaws, because right now there's 3 or 4 sets of bylaws, and that's one thing that we're talking about, of having a retreat to figure out the board and entity bylaws and structure and governance structure. So who's ever on the governance committee will be tackling that.
We did, as I recall, and Deb, you may recall, we did talk about that. We talked, especially Wildflower, because they had, it's a big institution, big budget, they had a
Yes.
separate board. And remember, we talked about that and we voted on it, and we voted no. Nathan and I, you may have been there as well. And we decided to subsume essentially all of those responsibilities and then subsume all of the quality into Lindy's quality. I'm not mistaken, right? Okay.
And on
It was brought up and decided.
Yes, it was.
on both the, particularly the finance, but to a lesser degree, the planning committee, there are discrete discussions about each of those entities as well. Separate financial statements for the entities, separate discussions on projects and progress in the planning.
The same thing with the quality committee, it's 2 separate within one committee meeting.
I'm only first year. how are we doing year over year?
Year over year with,
That graph, are there more yellows than last year?
there are, however, we did have quite a few fall off from the prior year. Some stayed and some are new. But yeah, this is going to be and should be an ongoing, just continual process. And what the Office of Inspector General talks about, they used to have a mandated work plan for themselves as a federal agency, to where they had it in regulation that they would have to update by November of each year. But then I think it was 2 years ago, they decided that they were going to have a dynamic plan, so that it wouldn't be that, if something, popped up around March, that they wouldn't have to wait till November to add it to the list. It was just a continual process, basically on a monthly basis. And so we're following something similar, to where, if something comes up and there's nothing to fall off, then great, it's just going to continue to grow. But hopefully, we address it enough that it just eventually we've got it ingrained enough in our systems and our processes that it doesn't need to be looked at anymore. So I don't know, that really doesn't answer your question, but.
Yeah, I think what you see is some of the things change based on taking on new entities. So that's where you see a little bit of the inching up on the yellow, is because of some of the risk of just having new service lines. So there are more issues to look at just related to that, where Nathan talked about with the new service line. So you are going to have new billing with Wildflower Court, with home health and hospice. So you'll see that reflected in the work plan. So there's definitely some changes on the work plan for this year.
I want to be sure I understand this graph and what it's telling us. So I just think maybe by analogy to a car, we're all used to getting in a car driving around. The thing that has the most destructive potential in the car is probably the fuel mixed with air, is highly explosive. But because of modern manufacturing methods, that's all pretty well worn down. I mean, gas stays in there. In our everyday experience, we don't see cars burning, although I have seen it. It's very rare. So that I think of that as very low risk, where using a car having a crash, that seems like there's more risk there, because just more to go wrong. The gasoline probably has greater potential for destruction, but the system's in place to contain it. So when I'm looking at that and I'm seeing things in red or green, some of these things like the information technology, that seems to me like that's got a lot of destructive potential, like the gasoline. But I'm not seeing it way over there in red, and I guess that's because you have determined that that's pretty well under control, the same way the fuel system in a car is. Is that, am I interpreting this correctly?
Correct. In specifically to that particular one, I think the big exposure right now is not having outside review on a, it's been a while since we've had the IT department reviewed from an outside entity. So going off of data from maybe 3 years ago and them saying, okay, here's your corrective action plan, here's what you need to do to make sure that this is where it needs to be. We need to have another one of those. And I believe that Chris has got something planned for that in the near future, and that made it onto the work plan. So yes, I can say as of what has been responded to in the interviews and responded to in the questionnaire, and going back as far as the last wholesale or holistic review, I would say yes. But I think what we need and the biggest exposure in this area is another look. we need to do another diagnostic test, if you will. Penetration test for firewalls, all of that.
Because I'm just kind of glancing at this, I see a bunch of things in the green, of course, that makes me feel good, so I just kind of tune those out. We have a number of things here in the yellow, and then there's one thing way over in the red, so that, of course, catches our attention. But then when I go and look in some of the more detail, I'm looking for that, I'm looking for this strategic planning, which is in the red. But then my eye goes right up a couple lines above us, and there is a physician financial arrangements. It's further to the red. So I'm wondering why the disconnect between the scanning tool, which is what we have on the screen, and the details that follow. Am I being clear?
So in the actual,
I'm on page 24 of 35.
sorry, I don't have the, which line item can you?
27,
27, yeah.
or 27 or 28.
Notice how far you are to the red, and then go down to the one that's supposed to be furthest. Oh, well, actually, that looks different from on my page. Let's see, 20.
Yeah, what is that, Nathan? The physician financial arrangement, is that compensation? Well, that's a broad word, isn't it, compensation?
Yeah, so are you talking specifically about 28?
Yes.
Okay. So collect and review existing contracts, including professional service agreements, medical directorship, and employment agreements for compliance with Star Cloud and anti-kickback statute. So this is part of, it's also actually on the work plan, down underneath on the, we'll get to this, but that's on the improvement initiatives. But there is not a comprehensive compliance tool to evaluate these arrangements. And this is considered by the Office of Inspector General and CMS to be a really big topic for them. So being able to review on the front end any of these arrangements that come through, whether it be a vendor or a provider contract, but then also an ongoing periodic review to make sure that it's still in compliance. Because what can happen is, let's say we have a specialty that comes in and we're really interested in getting this specialty on board. We might roll out the red carpet and we might pay them a lot more to entice them to come, right? The government allows for that. But what the government doesn't allow for is going beyond fair market value to the extent that it could be seen as you're overpaying them for the purposes of getting referrals. Right? So that would be your kickback piece of either anti-kickback or Stark Law. So they don't want that. So what we would need to do is if we roll out the red carpet and we say we're going to pay you above fair market value for the first year, 2 years, 3 years to get you enticed here, we can justify that by saying this is why we did it, right? But then in 3 years or whatever time frame, there should be some sort of mechanism that says, here's what we pay our people, and here's the formula, and here's the objective measure of how we figure that out based on region, based on location, based on MGMA, which is a professional organization that tracks all of this data nationally. We might even pull in the AHA, Alaska Health, and I forget what the acronym is, but the state information.
Hospital Association.
Yes, there you go. Thank you. So, and then we might even pull in, and this is in our policy as well, the Juneau Economic and Development Council data also has kind of this cost of living component too that we've also had. So there's a lot to these to make sure that compensation, whether it be, again, for a vendor or whether it be a financial relationship with a provider, that we're able to say that we're good. And right now, we might be good, but we just don't have a comprehensive compliance view into those areas yet.
And as a physician, almost 30 years, they had employed physicians here before, Alan Schlecht, for instance, and some other physicians, Susan Hunter Jones, the neurologist. But then it kind of wound way down, except Ben Miller, and now it's winding back up again a little bit with anesthesia. And so, as to Nathan's point, because we're delving more into these other arenas, we still haven't caught up to how do we assess, like, hey, how are we doing compared to like Anchorage or something. So, and we're competing with Surge.
But to return to my point, what is the relationship between all these individual ones and this, what I call the scanning tool, the first graphic we looked at? How do we go from this page to the first page of the risk assessment?
Okay, so this one is the basic areas, right? So compliance management is this guy. And then compliance management has several sub things, right?
He's being more picky though. I mean, I understand what you're saying, Cal. He's saying that the place on the actual bar and your summary table is different than on your individual table. Is that your point?
Yes, that's my point.
Okay.
So we went to the one.
So 28.
So as I look at the scanning tool, what I call the scanning tool, the first one, you see the furthest to the left, furthest in the red is the new service lines. Okay, so that's what we should be assuming. I assume that's what we should be the most concerned about. And then when I went down into the individual levels, I didn't find that was. I found other things that looked like they were further into the red.
Isn't it the aggregate of all of the subpoints?
Yes.
So,
Well, how do you aggregate these colors? I mean,
Subjective.
all right.
It's subjective. So yes, to Deb's point, if I may. So there are a lot of sub categories under each one of these, and the sum of that is reflected here. But number 28 by itself and 29 by itself, those are higher. So they might have other ones that are in the green that bring the whole category down just a little bit.
Yes, but as Boeing could explain to you very clearly, when you're looking at failure pathways, we have all kinds of cliches and aphorisms about this. A chain's only as strong as its weak link. When you're looking at the risk of something failing, you want to look at where there's a potential for failure. You don't want to, I don't know how to say that any clearer. We're looking for failure pathways, aren't we?
Yes, so that's why this kind of is a kind of gets you on the target, but this really narrows down into the areas that need to be focused on.
so you are only reporting of that aggregate. You are only reporting what's in the yellow, orange, and red in the detail. Is that what you're saying? Otherwise, you'd have more greens on there, and I don't really see any greens.
Yeah, no greens on there. In fact, there's very little yellows, because what I don't want is a list that's 200 or 300 or 400 long and there's really nothing to see there because they didn't raise to the level of needing to be addressed. And so that's what you're seeing. This is an assessment of the topics that should be addressed.
And then, sorry to just keep burning up time here, but what we have is a list of recommendations, risk assessment recommendations. So to whom are those recommendations being directed, and what will become of those recommendations?
So the recommendations are for the compliance program to actually address as a compliance program.
To you. No, we're not the compliance program. We're sitting here listening to the staff talking
We're
about
the
their
oversight.
compliance. Yeah, okay. Good, well, sorry, this is helpful to me. I hope I'm not wasting our time.
But I think that picture is confusing because you've looked at all of them in that category and then said, it's about there, right?
Mhm.
So that first picture or whatever to me, it's confusing. When I was reading this, I didn't figure, I'm glad you asked about this because I couldn't figure out what's going on.
Well, I think I understood that, I mean, the whole thing is really subjective. You got a bunch of experts around, you say, hey, what's important here? And people talked about it and they came up with what they thought was important. That's the basis here.
Right.
So,
Sure. And I will say, if I might add, that the group really is to spell it out. You've got senior leadership, you've got the executive directors, you've also got the revenue cycle team that are all part of the compliance committee. So there's a pretty good picture, and there's quite a few middle management, like with health information management, with registration, BFS. Those teams are also represented in identifying these areas.
but somebody is trying to tell the board, if I'm understanding this, so somebody's trying to tell the board, compliance management, information technology, pharmacy, these are areas that you, members of the board, who are ultimately responsible, you've got something hanging out here. You've got the potential to be very embarrassed and have some answering to do in these areas, and especially in strategic planning of services. That's the whole point of this graphic, isn't
Correct.
So what do we do about it?
it? Well, we have on the next page the recommendations, but then what do we do from there? I guess that'd be a question best directed to Gail.
So these are the things that you should be hearing about through the year. So as you see this, and if you go to the work plan, everything that Nathan has identified here, you should then be seeing on the work plan. And then you should be, then subsequent reports, there should be action items coming from the hospital and the work group addressing these. So by next year, hopefully you're seeing the red, the going to yellow and that. So there should be either monitoring or action items to mitigate the risk. Ultimately, that's what we're looking at. And if there isn't a way to mitigate the risk, how do you contain and monitor? That's your role, is to provide the oversight and be watching as a board.
So I have a question, if it's all right, Mr. Chair. What I haven't seen, and I know it's complex, but what I haven't seen, and maybe it's impossible to do, is the segue from the risk assessment to the work plan areas that tells us that number 28, or whichever one that we're looking at, is covered by one of these areas in the work plan.
Is this what's going to follow with the next item? Because we're going to move on from here where the big hand's gone around once already. The next thing we're going to come up against is the Bartlett Compliance Work Plan 2020.
Number 28 is on here.
But does it, I'm sure it is, but I can't, I can't get there without a lot of. Anyway, I don't want to kill a bunch of time with that, but it would be helpful to do a crosswalk with.
But or is her question going to be answered when we, or even touched on, or even hinted at when we move on to this next area of what's on the screen right now?
I'm ready to move on, yes.
But
I see it.
but are we gonna get back to her question?
Yes,
Yes, and number 28 actually will be addressed when Alrender is coming on in a whole different manner. So rest assured, that's being taken care of in another way also, so, but that's a whole another topic outside of that.
Okay, then should we move on to the work plan? Which I hope is gonna be the answer to the question, what do we do about it?
yes. Yeah, so the work plan, as you see here, is this internal work plan is basically a summation of the risk assessment. Because again, this is the internal piece, the one that we're looking at. So this turns into the monitoring and auditing. The other piece that I want to draw your attention to is the last one here, which is the implementation and improvement initiatives. These three are also included in the risk assessment. Because if we don't have a system or a process by which to monitor or audit, then that means we need to create a way to monitor or audit. So that's what these three areas are. So the new services committee is going to help with that furthest new service line piece. So it's not a one-for-one direct correlation as far as a crosswalk is concerned, but the topic's there. And then you've also got the same topic for number 28 here is create a compliance process for evaluating these contracts. We talked about the physician and vendor contracts. So that's the first one under improvements. So once those are in place, then we can go ahead and monitor and audit. And I will say, just as a side note, to Gail's point, there are certain things that you can only bring down as far as the risk rating. You can only bring it down so far. Because of the nature of some of these things, you're always going to have them in the yellow, right? So 340B, for example, is kind of a big deal.
High risk area.
Right, high risk area, you can put all the controls that you want in there, but you're still gonna have it as being at least moderate or somewhere in the middle. It's almost never gonna be green. Because it's just that complex and that much of a challenge.
So if I could summarize my understanding of what we've just listened to. So you went through the exercise, you developed the reds and greens and yellows, and that was a way to just get your head all organized so as to take us to where we are right now with this work plan, right?
Right.
There's not a one-to-one. I can't go to line 28 and then find line 28 in this work plan. But the people who put the work plan together looked at line 28 and incorporated that concerns. Is that a good summary?
Yes. And I would say in several places. Right. So if it's the request by Deb and the group, we could make
I don't
another.
want to take us down a rabbit hole. I just want to make sure that we've got all these yellows and oranges and reds, and that the work plan is addressing the high priorities. That's all I care about.
And the way the work plan is, sorry, through the chair, is it's dynamic. So if in 3 months, if we have a compliance concern risk that you feel is not being addressed through this work plan, then this work plan should be updated and readdressed.
And then if I could follow on, but the risk assessment is not dynamic. That's done once a year.
Correct.
And
Correct.
if a new risk emerges, you don't change it.
Yes, and through the chair, what you had us do at the last meeting is set a plan for this committee. So each year in the fall, we do an evaluation, and that will determine the cadence of the work of this committee. So that's what you wanted established. So there will always be an evaluation pre-risk assessment, so you have set the cadence for the work to be done.
Thank you.
And I would also like to point out, if I may, jumping to the next item a little bit, but not permanently, but we've talked about the compliance metrics that are just ongoing. If there's nothing to talk about, it's just the bare minimum of what is just always going to be standing work done by the committee, right? This, again, is dynamic. The work plan is dynamic based off of real life things that are happening, that are moving, and we're playing whack-a-mole, if you will. The metric list, those are just always going to be there. They're just always going to need attention. And the request was we just bring those, and if we want to discuss them, we can. If there's nothing to talk about, we just move on. It's just informational. What I'm suggesting is we could also, since this is only brought to the first quarter of each year based off of our last plan, we could also bring this as informational, almost like the metrics. So you guys could look at, the committee could look at this column right here, which would be the last performed, and it would show you what's been done and when the last thing was done. And you would now be getting some updates on that work plan on a regular basis. You may not need to talk about it, but you would just see it.
Speaking for myself, I find it useful and comforting. And then, yeah, I don't want to go through it line by line.
So, and here's your scenario, right? We've talked about IT being this big thing out there that could potentially have a lot of things that need to be overturned and looked at, flashlights, all of that every 3 years or so. So let's say in the next several months, maybe 6 months, we get this report and it's like, oh my goodness, hair on fire, right? That would, to Gail's point, become the priority in the work plan. And you guys would see that dynamic change, and you would also see maybe more things added based off of that. Does that make sense? And then you could see that, it's morphing, it's moving. This is the work that the compliance program is working in and moving towards based off of real-time data.
And Chris Letterman is your topic of education next committee meeting. So you'll have all things IT security.
Okay.
And I do know he is having there will be an IT consultant that will be on board at least a month before that next meeting, so.
The consultant is specifically for.
I am not sure what their scope of work is. I haven't seen that, but I do know there is an IT consultant coming in.
Do you have more to say about
I do. So we've touched on this first section. We've touched on the last section, which is kind of the initiatives, the kind of projects, if you will, projects more than monitoring and auditing. This education plan is pretty straightforward. This is also a part of a work plan. How are we going to educate frontline staff, physicians, the board? This should be pretty clear to you there. Now this section is where we look at the Office of Inspector General, we look at the state plans, we look at other federal or government agencies that are saying, here's a priority that we are looking at, and basically signaling to healthcare organizations that these are priorities for us, so you're on notice, basically. So you can go to the Office of Inspector General's website and look at their annual work plan, and you'll find that their active work plan has over 200 items. But it runs the gambit from everything from, ambulatory surgical centers to hospitals to home health, hospice, all of these different things. And they will say, here's our priorities, what we're looking at. So what you see here, 16, line 16 through 23, these are all federal. I've laid them out with the OIG at the beginning. And if you wanted, you could copy and paste this number into the OIG website, and then it would bring up kind of this write-up of whatever it is that you're looking at. In fact, this isn't in your board packet because it's a PDF, but in the Excel spreadsheet version, I've gone in and I've put in kind of more information about what this actually means. So when you look at nationwide review of hospice beneficiary eligibility, what does that even mean? Well, it means that the government is interested in making sure that people on hospice should be there. And they go into detail to say that the government is looking at beneficiaries of hospice and whether or not they have inpatient stays and emergency room things in their medical record before they actually get on hospice, because presumably that indicates the decline of an individual getting closer to being terminal. If you've got someone who doesn't have any history of hospitalization or emergency room visits, and then they automatically end up on hospice, that throws a red flag. Doesn't necessarily mean that it's wrong, but it throws a red flag. So they're telling us this is what we're looking at. So this gives us the indication that we need to be looking at that too in that same way, so that we have an answer for them if it ever does come to us in the same sort of question. And so you can go through each of these, potentially preventable hospitalizations for skilled nursing facilities. So this is where the government is looking at, we talk about compliance being fraud, waste, and abuse, right? One of the waste that they look at is overutilization. So if we have people at Wildflower Court and they're being admitted to the hospital because they've got a UTI, well, the government sees a urinary tract infection as generally preventable. So if Wildflower Court's not doing its job at preventing UTIs, there's overutilization because now they need hospitalization and elevated level of care that costs them more money, when the reality is Wildflower Court should not be having preventable UTIs, right? So they're looking at that. They're making sure that it's, those hospitalizations from a nursing care center is legitimate. So yeah, so when we bring on Wildflower Court, there's all kinds of things that they're looking at to make sure that we're reviewing these. So here's another one with hospice. They want to make sure that when hospice patients come to the hospital, that they're eligible as well, because a hospice patient in the hospital is a pretty expensive type of patient. So they want to make sure that they meet criteria too. So this would be a review of the record to make sure that all of our I's are dotted and T's are crossed. And this gets into the ethics piece, right? So the biggest ethics piece in some of these bigger organizations that have problems with this is when you have upper management telling the coders, hey, if it even smells like it meets criteria, then you need to code it as such, right? So there's some gray area that they're asking them to, err on the side of getting us more money, right? Then the coder's in this position where it's like, well, it's not all there. I can see the intent, but technically, if they audited us, we wouldn't be able to justify it. But I can see where, and so they go back and forth. And if you go on the site and say, yeah, let's go ahead and code it, then you would get that money and they would not question it until it does get questioned. And then they come back and they question it, and potential for questioning turns into these government random audits that we get once in a while. And they might find it. And then if they find it, then they're like, okay, now they've got a crack that they can start exploiting. And then if they start to see that you're upcoding in these cases where you shouldn't be, then that's where you get into a lot of trouble. And that's kind of the business ethics side of compliance and ethics.
So we've got about 10 minutes left. Are we going to be able to get through the two more things?
So unless there's any more questions, I feel like I've
Are there any more questions?
described the work plan. And then the next two things are informational. We can talk about them or not.
Let's see. I scanned these. I guess my question for you is, what of all of this would you like us to focus on? Is there anything significant in here that you think we should be paying a little attention to? And then I would go on, and the next thing I'm going to say is, how about those phone calls? It was just the one. I think that's already been explained. Oh yeah, yes, that's already been explained. Okay. So what should we look at?
So from the metrics, nothing. It's just business as usual.
I see a lot of hundreds.
And scrolling down here again, I mean, these are important, monitoring and auditing, and then also the repayments. But again, these look normal. So.
Okay, then the 5 things that executives need to know. Were you going to talk about that?
I thought you and Nathan were bringing that.
So yeah, I brought this to Hal. We discussed it a little bit. I think based off of our conversation last quarter, I guess it was December, Deb had brought up a question about risk, because we were talking about the risk assessment. And then we were also talking about, it went from kind of the compliance risk assessment to
Enterprise risk.
enterprise risk management, yes. And so the first one on this actually talks about that, which kind of caught my eye. I was like, oh, this is what Deb was talking about. It scares me every time. So anyway, I thought that there were some other good things in here as well, but wanted to point out that currently operationally, Bartlett has a decentralized risk approach. And if there was interest in exploring or asking for there to be an enterprise risk management, that would be kind of a governance question or thing that would be brought up there. But I will say, in doing a little bit of research, the American Society for Healthcare Risk Management, or ASHRM, they identify 8 different domains, I guess you would call them. And when you look at those 8 different domains, as far as the hospital is concerned, they are kind of segregated out. They use operation risk, and you could argue that SLT looks at those. You've got clinical and patient safety. This is where quality would look at that. You've got strategic risk, that would be board and SLT again. Financial risk, I would say that's the CFO and the CEO, and the board as well with the finance committee. Human capital is the 5th domain that they point out, and that would be HR and or your occupational safety and health for your employees. And then legal and regulatory, I would say compliance covers a lot of that, right? As its own program. I'm sorry?
And quality,
Yeah, as far as the,
COPs and that.
right. And then you've got technology, we've got IT that looks at that as directed by senior leadership, and then hazard, which would be our emergency management team. So that's where Ashram would say all of those kind of combined into a enterprise risk management, which would basically create its own department that these other areas would feed into. And as I've seen and looked at these, usually in hospitals, it's usually hospital systems. It would be corporate that would have the enterprise risk management. And then you would have the other hospitals that would have these different entities that would feed up to the corporate enterprise piece. Most smaller hospitals, if they have enterprise, it's not the true one department that rules them all idea. So anyway, just all I wanted.
Any questions? Any questions?
No, I understand all that, and I understand that we don't have the resources, but and this is a long-term aspiration. But what you just described to me, the diffused, decentralized, there is a lot of overlap in all of those. So my concern is where are our gaps and who's managing the gaps and who's it assigned to. So it's not, I don't want to take up any more airspace. We have 3 more minutes left in this meeting. But it's something that always, you never know when something's going to happen where one of the buckets, pods, areas of risk fails, and there's a domino effect into the other areas of risk. So.
And also the part of that is it focuses on more of a traditional risk mentality of hitting things, of being reactive, where a true enterprise risk management is being a proactive model. So right now we're still stuck in that reactive model and not looking future. So I mean that's something to, does the board want to look further?
Right. It's a discussion that we should probably have as a board and have with CBJ as well. How, what level of risk are we willing to accept? You're absolutely right. We don't have the resources to implement a full enterprise risk, but we can certainly, take some steps to coordinate.
I can see some difficulty communicating that to CBJ because we don't really have a big summary of risk. We don't have a way to say we're at 5 and we want to be at 3 or,
right.
We started earlier in the conversation with these visual tools that are aid to us, but they're not a quantitative thing. And they're not, so they don't translate from audience to audience very well.
So in any risk management policy or plan, the policy, there are some levels of how to mitigate risk. There's risk avoidance, which your safety plan, your quality plan, all of those plans are part of risk avoidance. There is insuring your risk. You're paying for someone else to accept the risk of malpractice or physical liability or property liability. So there's a number of ways to mitigate risk. Yes, we have to do an assessment, but you can identify the areas that fall into these buckets and figure out where to concentrate our efforts and resources. So we're a long ways away. I have just now taken us, so I really don't wanna take up a whole lot of airspace. And I probably won't spend any more time in this committee discussing it. It's something you're right, that we as a board need to discuss and figure out what's an acceptable level of risk for our organization.
Well, I think we're at the end of our agenda then, and I want to thank Gail and Nathan for pulling this information together for us. It was a good use of our time. I hope I felt. Okay, so we're adjourned then.
Next meeting in May?
I got my med quality.
Yeah.
Yes, you are. Sorry, there's a lot of them. That's for that.
Anything if you're ready to say that.
Did you, no, turn off the recording and all
Nothing.
that stuff?
Since we didn't sign a date.
Because I just wanted to make it.